Hello everyone, welcome once again to Words Made Easy. My name is Dr. Beston Wheeler and today I'm going to be taking you into yet another interesting topic called prolapse. A very common topic, it's an emergency and you need to know what to do once you're faced with called prolapse so that we save these babies, okay? So if you haven't subscribed to my channel, please subscribe so that you don't miss out on any content that I post. Please like and share with your friends. You know, sharing is caring. Okay, let's start. So, as I said, we're going to talk about cord prolapse today. A very, very important topic, okay, for us to know. Okay, so, okay, let's begin. Okay, so what is cord prolapse? Okay, let's begin with the definition of cord prolapse. Okay, so what is cord prolapse? So cord prolapse is the descent of the umbilical cord through the cervix ahead of or alongside the presenting part. So I want you to pay attention to the terminologies that I'm using, okay, to how I'm putting the words, okay. So this is the descent of the umbilical cord through the cervix ahead of or alongside the presenting part. So it can either be alongside the presenting part or the cord can go beyond, okay, can go beyond, okay, ahead of the presenting part, okay. So this condition usually occurs after rupture of membranes, okay. This condition usually occurs after rupture of membranes. So usually you know that the baby as the fetus is developing, okay, as the fetus is developing, you know that what is going to happen is that this fetus, as the fetus is developing, okay, together with the cord which is attached to the placenta, the fetus is going to be enclosed in what you call the membranes, okay, the amniotic sac, okay, which means that the cord of the umbilical cord is also going to be within the amniotic sac. Now, mostly once the membranes rupture, okay, once this amniotic membranes rupture, okay, you have the amniotic fluid coming out and you can have the cord coming out together with the amniotic fluid. So once this cord, okay, once this cord descends, okay, once this umbilical cord descends through the cervix, okay, it can descend through the cervix into the vagina, okay, or even beyond that, okay. It can be ahead of the presenting part, okay, or even alongside the presenting part. That is what we call cord prolapse. Now, cord prolapse can be in two types, okay. It can either be ovate or it can be occult, okay. It can be ovate or occult cord prolapse. Now, ovate cord prolapse, this is, okay, ovate cord prolapse, this is when the cord slips ahead of the presenting part into the cervix, the vagina, or beyond that, okay. So ovate prolapse is when the cord slips ahead of the presenting part, okay. So this cord is going to be ahead, so it will slip ahead of the presenting part. If the presenting part is the head, we call it cephalic presentation. It will slip ahead of the head, okay. If it's a breech presentation where maybe you may have the buttocks or the feet of the baby presenting, it may slip beyond that, and that is what you call an ovate prolapse, okay. Then it can be occult, okay. It can be occult prolapse, okay. So in an occult cord prolapse, this is when the cord lies alongside. It will lie alongside the presenting part, but not ahead of the presenting part, okay. So it will be on the side of the presenting part, but does not extend beyond the presenting part. Then we have what we call cord presentation, which is also known as phanic presentation. So this is a condition where the cord lies between the presenting part and the cervix in a woman with intact membranes. So the membranes are intact, they have not ruptured yet, and inside, what you find is that between the presenting part and the cervix, you have the cord there, meaning the cord is the closest part to the cervix, okay? And what is the problem here? if membranes rupture, if you don't know that this is a phanic presentation, or rather a cord presentation, and then the membranes rupture, the cord can slip and prolapse. Okay, so if you detect this, if you know to say this is a cord presentation, okay, you know that if you rupture the membranes, if the membranes rupture, the cord may slip and it may prolapse, and it can eventually lead to an occult cord prolapse or an ovate cord prolapse. So this is an image of what I'm talking about. So you know that this is a cephalic presentation. You have the fetus here. This is the cervix that has fully dilated, and this is the vagina. Okay, this is the vagina. And you can see that this cord has prolapsed. Okay, this is a cord that has slipped. So there's a space that has been left by the presenting part here. And this is the space where this cord has slipped through. Okay, it has slipped through and it has prolapsed. Okay, it has gone beyond, okay, even extending beyond the vagina. Okay, and this is the condition that you call cord prolapse. And what do you think this type of cord prolapse is? I'm sure you guessed it right. That is an ovate cord prolapse. Why? Because the cord is extending beyond the presenting part. Now, what are the dangers of cord prolapse? Why are we even discussing this condition? Because we can't discuss it if it's not important. What are the dangers of cord prolapse? Number one, complete occlusion of the umbilical cord can occur when the cord prolapses. Now, what is happening here is this cord that has prolapsed can be compressed. Okay? So when you look at this image, you will find that this is the head of the fetus, and this is a cord that has prolapsed. These are bones. This is a bony pelvis. Okay, this is a bony pelvis. Okay, structures are rigid here. Okay, which means that as this baby is getting born, as this fetus is getting born, as these mechanisms of labor are taking place, you can find that as this head descends, it will end up compressing the cord. Okay, that compression of the cord can lead to either complete occlusion or it can lead to partial occlusion. So either completely occluded or partially occluded. Now, what are we talking about? You can have complete occlusion. You say there's complete occlusion when there's compression of all the three vessels. Okay, all the three vessels are compressed, the arteries and the veins, the two arteries and the vein, and the one vein that you find in the umbilical cord. When all of them are compressed, then it is a complete occlusion that has occurred. Okay, but when there's compression of only the umbilical vein, then you have a partial occlusion. Okay, the other thing that can happen is that you can have vasospasm of either the umbilical arteries. So one of the umbilical arteries can undergo vasospasms. Okay, so when the cord prolapses, even when there's no compression, when it's exposed to the outside environment, which has got a different temperature, okay, it can stimulate vasospasms. In fact, even when you are trying to handle the cord, that handling of the cord can induce vasospasm in these particular arteries. And when we look at all these three things, the complete occlusion, number one, the partial occlusion of the cord, number two, and the vasospasms of the umbilical arteries, all these scenarios are going to compromise the blood flow and oxygenation of the fetus to varying degrees, and this can compromise the fetus. They can go into fetal distress, and the fetus may die. You may end up with a stillbirth. Okay, these are the dangers of cord prolapse, and that is why if you don't act very quickly, for as long as you wait, the blood is going to be occluded from the fetus. And remember, for as long as you wait, you are going to be compromising this fetus further and further. What are the risk factors of this condition? It's important for us to know the risk factors, okay? So the umbilical cord prolapse, okay, primarily occurs in two settings. So there are two basic settings in which a cord prolapse can occur. And what are these two basic settings? Number one, when the presenting part does not adequately fill the pelvis because of the maternal or fetal characteristics. So if the presenting part is not adequately filling the pelvis because of either maternal or fetal characteristics, we'll talk about some of these, okay? If it doesn't fill the pelvis, you know that the pelvis is some space that is supposed to be filled by the presenting part. So if the presenting part is not fitting within the pelvis, it's leaving out some space. It's either the presenting part is too small and leaving out some space. That space that it leaves, okay, the cord can slip past the presenting part through that particular space, and you can end up with a cord prolapse, okay, either ovate or occult. The second scenario is when there's an obstetric interventions. When we do certain obstetric interventions, when these obstetric interventions are performed, and these interventions end up dislodging the presenting part. So it can be when obstetric interventions are performed that end up dislodging the presenting part. So this is a case where the presenting part fills the pelvis adequately. But then because of what we are doing, because of our obstetric interventions, okay, because of our obstetric interventions, we end up dislodging the presenting part. And that can lead to incomplete filling of the pelvis by the presenting part. A space can be left and the cord can prolapse. Let's talk about these things. So what are these things that are falling under these categories, these risk factors? Number one, the risk factors, okay, in these conditions we're going to mention, most of these conditions I'll mention, the presenting part does not adequately fill the pelvis. And so there will be room that will be left for a prolapse to occur. Okay, so number one, malpresentation. You may have a breech presentation, a transverse lie, an oblique lie, or even an unstable lie. In that situation, okay, let me give an example of a breech presentation. In a breech presentation, what you have presenting is either the buttocks or the feet of the baby. I'll give an example of a footling breech where the feet is, the baby appears to be standing, okay, where the feet, where you have the feet presenting. Now, what happens is that you know that these feet are not obviously going to fill the pelvis adequately, okay, so there will be space that will be left, okay, and the cord can prolapse from there. Even a transverse lie, the baby is in transverse, okay, so if the baby is in transverse, you know that obviously the cord can easily prolapse, okay. What am I talking about? Okay, so let me just show you something. Let me just show you what I'm talking about, okay. Let me just draw it right here, okay. So what do I mean? What I mean is if this is the woman, okay, this is the woman, okay, and then I'll do this to show you that, okay, this is the pelvis, okay, we'll do this, okay. So then you have, let's take for instance, you have a breech presentation. So in a breech presentation, you have the baby lying in this direction, okay. So this might be the baby, okay, and then you have the feet like that, okay, you have the feet like that, the feet of the baby like that. Forgive my drawing, okay. So if you have such a presentation, this is a breech presentation, okay, you've seen. So this is the uterus, okay, so this is the uterus, okay, this is the uterus, okay, this is the cervix, okay, this is the cervix. So if this is the baby, these are the legs presenting, okay, this is a breech presentation. You have the head, okay, this is the head of the baby, okay, this is the head of the baby. So you have the head of the baby here, okay, and these are the feet. So the cords, okay, you have the cord, the umbilical cord. So there's space that has been left. So this cord can easily slip around, okay, like that. It may slip around, okay. Let's say the placenta is here. The cord may slip around like that, okay. It may slip around and prolapse. So because of this malpresentation, the space that has been left out, this presenting part doesn't adequately fill the pelvis. And because of that, you have the cord prolapsing. So that is what we are talking about. Okay, that is what we're talking about. Okay, let me just erase this. So I hope that's clear. Another situation, this is the same thing that is happening when you have, it's the same thing that is happening when you have, it's the same thing that's happening when you have an oblique lie or unstable lie, okay? If you have, let's take for instance a transverse lie, the fetus is lying transversely like that. Okay, like that. Which means that there's a lot of space here. This cord can easily prolapse. Okay, the cord can easily prolapse as it goes and inserts on there. As it goes and inserts on the placenta. Okay? So that is what we're talking about. This is the same thing, except for if it's an oblique line, the baby will lie in this direction. You see? So that is what we're talking about. Okay. So the other risk factor apart from those, is okay, sorry. So the other risk factor apart from these is preterm gestation age. So preterm gestation age, I'm sure you know that premature babies are smaller, okay? They're born too early. So if you have a preterm gestation age, the baby is small, and so the baby, because the baby is small, they cannot fill in the pelvis. So there's space left. A low birth weight, the baby still is small. The weight is, they have a low weight, and the baby is small, so the cord can easily prolapse. A second twin, remember the first twin is born, the second twin can even change the presentation. It can become a transverse, okay, or an oblique, okay, the second twin. And also because once the first twin is born, okay, once twin one is born, there's room that remains, a lot of room that remains for the second twin, and the cord can easily prolapse. You can have a low-lying placenta. If the placenta is lying near the os, obviously because the cord is coming from the placenta, meaning the cord is going to be near the os. Okay, and if it's a low-lying placenta, usually low-lying placentas and placenta previa, they're associated with malpresentations as well. Okay, and that malpresentation, we said it's also part, these malpresentations are a risk factor for cord prolapse. You can have pelvic deformities, then you can have uterine malformations, maybe you may have tumors. All these malformations may lead to malpresentations, and that can increase the risk of cord prolapse. You can have external fetal anomalies, also leading to malpresentations. You can have multiparity. Remember, if you have multiparity in patients that are in multiparous women, okay, the uterus is usually lax, and then because of that laxity, okay, of the uterus, you have more room for the baby, and then the cord may prolapse from there. Polyhydramnios, also you have so much amniotic fluid in the uterus, okay, so much amniotic fluid in the amniotic sac, and so you have more space for the cord to prolapse. A long umbilical cord also, remember, if the umbilical cord is long, chances are high that it will reach the cervix and prolapse. An engaged presenting part, if the presenting part is not engaged, it's high in the pelvis, there's obviously space that has been left within the pelvis, and because of that space that has been left within the pelvis, you can have the cord prolapsing through that space. Prolonged labor and also atypical placenta cord insertions, for example, a velamentous cord or a marginal insertion of the cord. So all these risk factors, most of these risk factors I've mentioned, are going to lead to the presenting part not adequately filling the pelvis, and this is going to leave room for the cord to actually prolapse, and then you end up with cord prolapse. What are the obstetric interventions? So risk factors that are obstetric interventions, okay? What obstetric interventions would increase the chances of a cord prolapse? So obstetric interventions account for 50% of cases of cord prolapse, and these include artificial rupture of membranes, especially with an unengaged presenting part. That's why if the presenting part is not engaged, and then you rupture the membranes, what you have is that because of that, because the presenting part is high in the pelvis, it doesn't engage, then you rupture the membranes, the cord will easily slip around that presenting part, and the cord will prolapse. Okay, cervical ripening with a balloon catheter. Remember, you're introducing a catheter inside, okay, and as you introduce that catheter to try and ripen the cervix, okay, that procedure itself may dislodge the presenting part, and that can lead to a cord prolapse. Induction of labor is another thing, okay, because even this point number 2 is also part of induction of labor, okay. Application of an internal scalp electrode. Remember that this scalp electrode, you're applying it where? On the scalp of the baby, internally, meaning you're going to push through the vagina, through the cervix, and apply this scalp electrode on the baby. This is the same thing as insertion of an intrauterine pressure catheter. This is just the catheter you're going to insert inside the uterus as well, okay, to monitor the fetal well-being, okay. And while we are doing that, you can dislodge the presenting part that was adequately filling the pelvis, and as you and because of that dislodgement, the cord can easily prolapse. Manual rotation of the fetal head, obviously, it will dislodge the head. Amnio infusion. This is why you infuse sterile saline within the amniotic fluid. That will expand the volume of the amniotic fluid, and it can easily lead to dislodging of the presenting part. External cephalic version and internal podalic version, because this is where you are like rotating the baby, isn't it? Let's say this baby is in breech and you want to rotate. So you are rotating the baby. Because of that rotation of the baby, okay, that is going to lead to dislodgement of the presenting part that was adequately filling the pelvis, and the cord can easily prolapse. This is one of the complications of external cephalic version. Application of forceps or vacuum. So as you apply your forceps or vacuum, you can easily dislodge the presenting part and the cord can prolapse. So all these are risk factors. So remember, we said risk factors of cord prolapse can be into two. It can be risk factors, okay, things that are causing the presenting part not to adequately fill into the pelvis. It doesn't adequately fill into the pelvis. Or this presenting part was adequately filling into the pelvis, okay, and then there are some obstetric interventions that are performed that dislodge this presenting part. And all these factors can lead to cord prolapse. How do we diagnose this cord prolapse then? So cord prolapse, I must mention to say it's a clinical diagnosis. So clinically, there will be sudden fetal bradycardia or variable deceleration on CTG. So variable decelerations on CTG, okay, variable deceleration on CTG indicate cord compression, okay. So that's why you find it in cord prolapse. So what type of decelerations do you find in cord prolapse? Variable deceleration. This is where you don't have a relationship between the fetal heart rate tracing, the tracing of the fetal heart, okay. You don't have a relationship between those and the contraction of the uterus, okay. So they are just this deceleration can come before, it can come after, or it can come together with the contraction. That is a variable deceleration, and that is what you find on a CTG in a patient with cord prolapse, in sudden fetal bradycardia, okay. This especially when you have, the clinical picture is that you end up with, you notice a sudden fetal bradycardia or variable decelerations on CTG after you rupture the membranes. You should suspect cord prolapse in such a setting. When you do a VE, there will be a visible or palpable cord in the vagina. So you can visualize the cord, or you can even palpate it while you do your VE on the vagina. And this cord can either be pulsating or non-pulsating. If you find that there's no pulse in the cord, meaning the baby has died, okay? Meaning the baby has died, and meaning the blood flow has stopped. So the baby has died. So that's why the cord is not pulsating. And then it can even be pulsating, meaning the baby is still alive. You need to save that baby. Ultrasound or Doppler scan, these may confirm the cord position, especially in occult cases. However, it must be noted that the cord prolapse is a clinical diagnosis and an emergency. So there's no time for you to be sending a woman for ultrasound scan. So ultrasound scan is more useful, especially antenatally, to detect the cord presentation, because you know that if there's a cord presentation, when membranes rupture, chances are high this cord will prolapse. But otherwise, when you diagnose cord prolapse, it's a clinical diagnosis. Once there's these things that have been mentioned here, you have these examination findings, you need to start preparing the woman for delivery, okay? Because this is an emergency. You don't have to delay, because whatever minutes you take, that fetus will remain compromised. There will be no blood flow to that fetus, and they will be compromised as long as you wait until that fetus dies. So how do we manage cord prolapse? What's the management of cord prolapse? So remember that cord prolapse is an emergency, as I've said earlier. So therefore, number one, call for help. In medicine, help is all you need. We value teamwork, so you can't do it alone. So number one is call for help. Number two, prepare for emergency delivery. So call for help, Start preparing for emergency delivery, okay? The nursing team, the anesthetists, okay? The nursing team, the anesthetists, obstetricians, the theater, okay? Pediatric providers, all these people should be alerted and they should be ready, okay? While OT, you may need to perform a cesarean section, so you may need anesthesia, obstetricians, operating theater to be ready, okay? You may need maybe theater nurses, the nursing team should be there, so whatever the case, okay? Even pediatric providers that are specialized into pediatric care, okay, and neonatal resuscitation. So you need these to be ready. So that's why you need to call for help, because you can't be attending to the woman and then you are the one who's running about to inform people. So you need a team, okay? You need a coordinated team. So then after this, you relieve the pressure on the cords. So these things are happening simultaneously. It's not like they're happening simultaneously. You go for help. As you go for help, quickly you assign someone to go and inform the team, okay? The team comes, you have a team there. As you are doing this, as the team is coming, you're already doing these intrauterine resuscitation maneuvers. So relieve the pressure from the cord. How do you relieve the pressure from the cord? Because the presenting part, as long as you leave the woman like that, the presenting part will be compressing on the cord. And because this presenting part is compressing on the cord, it will be cutting off blood supply to the baby. And that is going to be compromising the baby. Remember, the baby's life is at stake here. So number one, how do you relieve the pressure? Number one, manual elevation of the presenting part. So while preparations for an emergency cesarean section are made, the clinician will place their hand in the vagina and gently elevate the fetal head until it is not compressing on the cord. So the hand is passed in the vagina and gently elevating. So this is effective. But the problem is that although it is effective, a prolonged period of manual elevation can be difficult for both the clinician and the patient, because you can get tired. It can be very uncomfortable for the patient. The other maneuver that you can do to relieve pressure on the cord is maternal positioning. So here you can put the woman in a knee chest position or a Trendelenburg position. Now when you put them in a knee chest position, gravity is going to help you to push the presenting part away from the cord, and that will prevent cord compression. Okay, a knee chest position or a Trendelenburg position. Bladder filling is another thing. So you can fill the bladder. So catheterize and rapidly run 500 to 700 mils of normal saline via a catheter. So when you catheterize the woman, you push in 500 to 700 mils of normal saline in this catheter, and this is going to distend and balloon the bladder. So the urinary bladder becomes distended and ballooned, and this will prevent the descent and gently elevate the presenting part, preventing compression of the cord by this presenting part. So these are some of the maneuvers you can perform to actually relieve the pressure. So what are these maneuvers? I'm sure you can see. This is a picture showing you a hand. This is gently elevating the cord, the presenting part, so that it doesn't press on the cord. This is a catheter that has been inserted, and then you have a normal saline running. You balloon this, and as you balloon this, it's going to prevent further descent of this presenting part and gently elevate it. Then you can have, this is what I was talking about. This is a knee chest position, okay? Put the woman in a knee chest position. They will be like this. You can even give them a pillow for comfort. And when you do this, remember this cord is here, prolapse. Because of gravity, this presenting part is pushed towards this direction, and this is going to be relieving the pressure from the cord. This is what you call a Trendelenburg position, and remember this is a cord that has prolapsed. Gravity will help you push the baby away, and this is going to leave some room for the cord to breathe. There will be no compression of the cord. This is where you have elevated. This is a pillow that has been put to elevate the pelvis of the woman, and this is also going to help. Gravity is helping you also to push this cord away, this presenting part away from the cord. And this is a Sims position. So even the Sims position can be used. It's a Sims position with a pillow. Okay, this also, look at the shape. Okay, it is helping you. Gravity is also going to take place to help you push the presenting part away from the cord. This is going to leave room for the cord for blood supply to continue to the baby. All these maneuvers, this is not a definitive management. You are performing this maneuver to relieve pressure on the cord to buy you time as you prepare for delivery. Note that. Okay, so then put the woman on oxygen. Make sure you put the woman on oxygen and IV fluids. Remember, you need more oxygen so that even though the blood supply is a little bit compromised to the baby, you will increase the oxygen so that you have enough oxygenation to the fetus. IV fluids as well. This also prepares them for OT because they may be going for to theater where you're going to do a definitive management, which is a Caesar. Okay, I must mention that it's not always that cord prolapse is not equal to Caesar. No. So administer a tocolytic. You may need to administer a tocolytic. So a tocolytic is a drug that will prevent the contraction of the uterus. So if there are uterine contractions, a tocolytic, lysis means breaking down. So it will break down the contraction. Toco means contraction. Lysis means breaking down. So these are drugs that will break down the contraction. So they will stop the uterus from contracting. So a rapid acting tocolytic, for example, terbinafine or terbutaline, that can be a tocolytic that you give. So this can be administered to reduce the pressure on the cord from the uterine contractions. Because when the uterus is contracting, as the uterus is contracting, it is pushing the presenting part towards the pelvis, okay, and that can compress the cord. So to relieve that compression and pressure on the cord, you can administer a tocolytic. Monitoring of the fetal heart as you prepare for theater. So make sure you monitor the fetal heart. When you diagnose cord prolapse, monitor the fetal heart. Monitor the fetal heart. Make sure you monitor the fetal heart, okay, so that you are able to detect if there's fetal compromise. If fetal compromise is happening, you can even connect the CTG if your facility has. The definitive management, however, is delivery. So you need to deliver by the most safest and fastest route that you can use. And usually this is cesarean section delivery. Cesarean section delivery is the mainstay, but you can perform vaginal delivery only in selected cases. For example, these are some of the examples of cases in which you can do vaginal delivery. When the vaginal delivery is imminent, okay, and birth will be accomplished quickly and safely. This is where you have a cord prolapse, but the cervix is fully dilated, the head is engaged, and you know that vaginal delivery will take place very quickly and safely. You don't need to start sending for Caesar. You can deliver vaginally, and this should be assisted vaginal delivery. You can use vacuum, okay, to deliver this, because you need to be as fast, as quickly as possible, and as safely as possible. So if there's a prolapse after delivery of this first twin, so after you deliver the first twin and there's a prolapse, you can quickly deliver vaginally because the cervix is fully dilated, the cervix is adequate, the pelvis is adequate for vaginal delivery. So this is where you can do delivery, vaginal delivery. A non-pulsating cord. A non-pulsating cord means the fetus is not alive. So if the fetus is not alive, there's no need for you to start sending for cesarean section. Why? Because when you send to the cesarean section, this is an operation, it carries risk. Okay? The main purpose why you do Caesar very quickly is because you want to save the baby. But then if the baby is dead, you send for C-section, you put the mother at risk of this anesthesia, at risk of surgery. Okay? And then she'll also remain with a scar. It will be emotionally distressing. So the best is actually just perform a vaginal delivery, let labor progress normally, and then deliver. But otherwise, in these other cases, you need assisted vaginal delivery. So in cases of vaginal delivery, it is usually assisted vaginal delivery. But for a non-pulsating cord, allow for spontaneous delivery to take place. Take caution. For an overt prolapse, minimize manipulating an overly prolapsed cord and avoid exposing it to cord environment because this may exacerbate poor perfusion by inducing spasms on the umbilical artery or the arteries. Okay? So what do you need to do then? Gently replace an overtly prolapsed cord in the vagina and keep it moist with wet, warm gauze. So gently replace it and keep it moist with this. Don't start manipulating it time and again, exposing it to cold environment. That will cause spasms. For an occult prolapse, proceed with an agent delivery on the fetal heart rate tracing. So if resuscitation ameliorates the concerns that you have, the baby's your maneuvers, okay? If your resuscitation maneuvers have ameliorated your concerns, then you can do expectant management, okay? It could be reasonable. Let's say this is a woman at 8 centimeters. You do those maneuvers, you find that the compression on the cord is done and everything, you can do expectant management and then you deliver, as in contrast with ovate. If it's an ovate prolapse, you don't have time for expectant management. But again, I must mention, it should be in a setup where you are able to monitor the fetus properly. But otherwise, if you are in a facility where you can't monitor, you can't monitor properly, okay, this fetus, you don't have equipment, or you're unable to monitor, okay, properly, it's better you just go on and deliver, okay, if you've diagnosed a cord prolapse. So this is just a station. This you can pause the video and look at this question. It's an ask station, and let me know what you think in our next session. Let me know what you think in the comment section. Sorry. So this is where we end. Thank you very much for watching. Thank you very much for listening up to this point. I hope it was helpful. And if it was helpful, please don't forget to subscribe. Don't forget to click the like button. And don't forget to share with your friend. Until next time, God bless you.